Hello and welcome to another Accurx Keynote on total triage models. This time we had our CEO Jacob and Dr. Amar Ahmed from Wilmslow Health Centre talk through some lessons on implementing total triage. If you're keen to find out more about total triage, visit the link in the description below.
This is what the model looks like. Wherever the requests come in from, online, on the phone, through the app, they go into the same queue. Those patients are asked the same questions. What's the problem? How long has it been going on? Is there anything you're concerned about? How would you like us to help? And then based on that, those requests are triaged. Where possible, those are dealt with through messaging. If you need some more information from a patient, that's collected through a Flurry. But all requests going through the same flow. So what have we learned from the practices doing that? So the first thing we learn, and perhaps counterintuitively, is make it as easy as possible for patients to submit a request. So a lot of practice websites we go to look a bit like this, and you have to, my practice is like this, so you have to sort of dig around a bit to find the link to submit a request. And actually, it's often easier then, once you've clicked around a few places, to just call up the practice. Here is an example of Wilmslow Health Centre, where as soon as you hit the website, right in front of you is that option to get in touch. So surfaced it really prominently to patients. And then the second lesson is, once those requests have come in, that all of the inbound is triaged in the same ways. That's asked the same questions, going into the same queue of work. And so one of the biggest signals to us of if a practice is doing total triage well is, are their reception team creating a lot of requests? And those are patients who call up, who maybe they can't use, they're not as comfortable with using technology, or maybe it's just they're used to calling up. That's how they get in touch with their practice, and so they're, that's their behaviour. They call up and they want to speak to someone, so they ask those questions, and so that's something that reception teams use. Now, one of the nicest benefits we've seen out of this is that actually receptionists tend to have fewer calls but longer calls, because they're spending longer on the phone with patients rather than just trying to get them in as an appointment quickly as possible and then get off the phone. They're taking the time to go through those questions with each patient. And we hear from reception staff that actually makes them feel more in control. They're not feeling like they're caught in between patients who are, sometimes being abusive, or just being, quite difficult around, really, really wanting that appointment, even, when they're all gone. Sometimes understandably, and then also hearing from clinicians, why were these patients booked in who didn't necessarily need to be seen? So we've seen, that impact for reception teams. The third lesson we've seen is having a really experienced GP do the triage. And again, this is slightly counterintuitive for lots of practices, because triage is this new activity. And so they say, well, let's put in place, actually our GPs are really, we don't have enough of them. It's hard to recruit. Let's see if we can get one of the admin team to do that, or let's use one of the trainees. But the crucial problem with that is that their threshold to then book things into an appointment is very, very low. Whereas when you have an experienced GP doing triage, it's much, much higher. That's not new to general practice. That's well documented in the A&E setting, where there have been these trials of put a consultant on the door, and lots of things can be resolved with more quickly. Now, some of the best examples of this are practices where they don't just have their GP triaging, but they pair them with one of the admin team, who can, that patient needs a chest x-ray, they can go off and order it, or they pair them with a trainee, and so that trainee is then learning these skills in triage, which we learned, we didn't realize this before, weren't actually part of medical training, learning how to triage. It's all designed around the consultation, taking a history, whereas triage is this very, very different skill. When we sit with, we see in practices trying to do it, where they're not used to it, and staff trying to do it, but they're not used to it, and they're trying to diagnose. But actually, the practice is doing triage well. If they've got a patient with abdo pain, or a parent who's worried about their 9-month-old, they're not trying to work out what's wrong with that patient, unless it's clearly 999, go to A&E. They're just trying to work out, do we need to get them in for an appointment? Let's get them in. And so what we then see in those practices is, when they have someone experienced doing that, the actual time from getting that request and opening up to resolving it marking it as done, on average, it's just 38 minutes. So things are throwing through very fast. Now, that's not 38 minutes of that person looking at it. It's a lot less than that, but that's how long the patient's waiting often for the next step, the next interaction. So those are the first three. I'm going to try and quickly, get through the remaining ones so we can get straight into the conversation. So the next one we found from practices is when triaging, assigning for both skill mix and for continuity. Now the skill mix piece is obviously there's been a huge push on ARS roles, but even before that, just on having a more multidisciplinary team. One of the patterns we've seen at practices is those roles getting, the pharmacist getting booked up, the physio getting booked up, but not actually taking anything off the GP, because patient, the normal behavior is patients call up, they want to see a GP, reception books them into a GP. And so triage is this great opportunity to say, well, actually, who is best placed in our practice in terms of their skills, in terms of their availability to deal with this. And then the same for continuity. And the distinction I draw around continuity is sometimes it's really, really important. Sometimes it isn't. But the best judge of that tends to be a triaging GP. So I use the example of, when I got shingles, I didn't care who I saw. I just wanted to get my acirculator as fast as possible. But for some patients, that will be more important. They might have other underlying health conditions. They might have more complex needs where actually continuity is really, really important. But the best judge of that tends to be an experienced GP who can triage. And so what we've done is we've done a lot of work on how we make the inbox more collaborative. So if you've got a wider team looking at it, you can see who else is working on things. And it's not just triaging into appointments, it's triaging into roles and saying, right, the physio can deal with this request, and they'll work out if this patient needs an appointment or we should, signpost to self-refer physio. Then the next lesson we've learned is if more information is required from a patient, collect as much as possible through collect as much as you need through a structured flooring. So there are examples of this. We include things like if a patient presents with a UTI or with a back pain or with a sore throat, or things like patients requesting a repeat combined oral contraceptive. But what's great is practices have now made about 10,000 of their own custom flores to collect this data. And the initial driver of this is the time savings. So patients filling this in their own time instead of taking time in the consultation. But what we quite quickly started hearing about was these cases where they picked up in the flooring something they wouldn't have picked up in an appointment. And that might be a patient presenting with lower back pain who actually had cauda equina was one example we heard. Another was patient presenting with a query UTI, but who actually had pelvic inflammatory disease. And the practice saying we probably wouldn't have picked that up in a 3-minute rushed phone call where we're asking a few questions, these sort of rarer but significant presentations, but actually because a patient could go through and fill these out and a much more thorough set of questions in their own time, they were able to pick them up. So using flows to capture structured data. The next we've learned is make it really, really easy for patients to reply, which again is slightly counterintuitive. Practices say, well, in fact, I remember before COVID practicing, well, if you let patients reply, we're going to turn this off. And so there's the ability to, as people are probably familiar with, like solicit a response. And total triage practices tend to use this a lot more. And they use this for a few reasons. One, they've found that if a patient still needs something after their response, that might be they've had a rash on their arm, they've been sent a EPS script for some topical steroid cream, and everything's probably resolved. But if that patient has another question, actually going back to the start is not just a poor patient experience, but very, very inefficient for the practice too. Multiple people have to look at it again, triage it, maybe it's seen by someone else. But the other thing those practices have found is it provides a lot of reassurance that patients are much more comfortable being told, I've assessed you, let's monitor this for 6 weeks. If there's still a problem, get in touch. But actually, let's not start any medication or take any other steps now. Whereas before, if they're told that they're going to, they feel like they're being fobbed off, they're going to have to start going through, multiple weeks of waiting again to get back in touch. Now they know they've got a direct line to a direct channel to reopen that request with the same person. But perhaps the most surprising thing we found, and one of the nicest things we found, is when practices enable that quite a lot, enable that response, and for the patients who, you know, they know aren't going to sort of abuse it, they do get quite a lot of responses, but a lot of them are saying, thank you. And, you know, I feel much better now. Thanks for dealing with this so quickly. And in medicine, we're so used to only having the negative feedback loop, only hearing when things go wrong and the patient, you know, maybe presents, ends up getting admitted or comes back because they're not well, rather than the positive loop of, you know, most of what we do actually works and people feel better. So that's one of the nice things we found through making it much easier for patients to apply. Right, number 7, working from the inbox rather than the appointment book. And this sounds like a really, really like sort of almost like logistical minutiae that, like, how could this possibly have an impact on the productivity of the practice? But the analogy I use here is, imagine all of the emails that you got, whether they are directly to you or to a large group of people, whether they require a response or not, whether they, a junk mail or sort of, newsletters you're signed up to, all quite, actually quite detailed, and you put time into crafting a response. All those emails, you put in the same 5 minutes or 10 minutes in your calendar for every single email. And then we're constantly just jumping back between your calendar and your email, saying, right, that's the next one I need to deal with, and then going over to your email, writing the email. I mean, it sounds nuts, but that's literally what, if you're working from the appointment book, that's what you're having to do is be tied to this appointment-based model of everything having the same length of time and this back and forth. And it's really, really hard to collaborate. The appointment book isn't built around collaboration. You can't go and put in notes and change the assignment and things like that. So total triage practices tend to work from there. The next lesson we found, and if there's one thing I'd love you to take away, and I'm very interested to hear Amar's examples and experience of this, but these practices are resolving as much as possible with messaging. And when you actually start to ask about the volumes, somewhere between a quarter and a half of what would have been an appointment before COVID is now being resolved through messaging. And that, in itself might not sound big, but actually when you look at the numbers and you look at, right, if we could take a quarter to half hour activity instead of it needing a 10-minute appointment or a 5-minute phone call, but which is never a 5-minute phone call, it's sort of, a few minutes of phone tennis and then the phone call, and deal with it in a couple of minutes of clinician time, even if that's only 25% of the volumes, you very quickly get to some quite big numbers. You very quick, 6,000 more FTEs is more than the government commitment and target around 5,000 more FTEs in the workforce. So, really significant numbers. And, on an individual practice, this looks like the equivalent of, having around 1.5 GPs more in the team with that conservative estimate. That doesn't include a lot of the wider savings from having more optimized workflows, things like boosting staff morale, which improves retention, but all coming from this point of how do we deal with as much as possible through messaging. Last two, so lesson number 9 has been telling patients how this works at every single touch point. So there's obviously things like explaining it through the website, which your website does a really great job of, but also it's all the interactions. There might be a patient who's really insisted on having an appointment and didn't want to answer the questions, and then we see practices take an extra minute at the end of the appointment, say, look, well, I was happy to see you today, but just so you know, next time we can actually see you much sooner and help you much sooner if you answer some of these questions, and the right person in the team can deal with it. Or getting reception to explain to patients why they're working in that particular way. Having posters in the waiting room. One practice we met with took the data to their PPG and said, right, here's how many patients we can see each week if we put in 10-minute appointment blocks, and here's how many we're seeing at the moment working this way. And we just couldn't do it. When they showed that to the patients were saying, well, why on earth were you doing it that way before? So really, really bringing patients on that journey. And then the last lesson, and it's one I'm really looking forward to discussing, is just constantly iterating that how total triage works in the practice. And that's everything from when staff, how many staff they have on triage, and is it more on a Monday morning, and when a routine appointments to balance capacity across that and make sure you've got enough capacity for the more urgent things, all the way through to, we go back to practices who have made the waiting room smaller and built a triage room where the GP can sit with the admin team with the trainee, or who've done a whole load of training with their reception team, or who've changed pathways for what happens when a patient gets in touch with a UTI or a patient with hypertension gets in touch. But this continuous iteration and improvement has always been where a lot of, the initial benefits, practices get after they get through that initial hump of getting through that unmet demand, but actually these iterations are when a lot of the others come. So one example of this is practices using their data to understand, okay, what size of workforce do we need at different times? What level of demands can we expect? So I wanted to quickly take us through some of those learnings. What we find is that in these practices that we've learned these things from, what it ends up meaning is that they can resolve more things without an appointment, and they can actually give patients a much quicker time to resolution. So 98% of those requests resolved within a day. But also what's really nice to see when you go into these practices is that sort of calmness that it's never completely calm. There's always lots going on, but that they've got time to go and discuss the more complex cases, time to spend longer with more complex patients, time to go and sit and have lunch together and make a cup of tea, or to talk to us and without us feeling bad because the phones are ringing off the hook. So those are some of the learnings. But I'm now, as I said, very privileged to have Amar here, and you probably want to hear from him and the journey at Wilmslow. So, Amar, do you want to give everyone a quick introduction to you and your practice?
I'm Ahmed. I'm a GP, past 23 years, very busy, semi-rural practice, high affluence, but also pockets of deprivation. Been a GP trainer as well. That's me.
Great. And so first of all, I'd love to understand, what drove your practice to work in this way and to change to work in this way? What made you take that plunge?
So we were right in the middle of the pandemic, and for some reason, demand had gone through the roof. We were really struggling with demand, and we were finding that it was the loudest or the patient with the sharpest elbows that really got the appointments. And we just felt there needed to be another way where we could give the appointments to those people really in need, and maybe we'll see everyone, but would have some kind of way of dealing with it safely and efficiently to make sure that the people that needed to see us soonest saw us. We were also one of the very first practices to use Accurx texting. Accurx saved the NHS during the pandemic. That's not an exaggeration. And at the time, Accurx kind of approached us to say, look, this is our next product. We were actually looking at a total triage product with another company, but when Accurx approached us, we thought, wow, we could develop this together. And it was a really good journey to be on.
That's very, very kind of you to share, and definitely most of the credit goes to the credit goes to genuinely to I often say we are not the innovators, our users are. We want to be there to enable it. But I'm wondering, so you're in the pandemic, you've got patients, as you say, patients with the sharpest elbows getting that time. What was the process you went through to make that transition?
So it was constantly evolving. We were listening to our staff most of all. We introduced clinical huddles. So every day we meet for a coffee and we discuss things, and there were themes evolving there. And one of those was that I can't get to see my cancer patients, my elderly patients who really need to see me because I'm seeing something really, really trivial, which is really important to that patient. But my skills need to be used in a situation where we are scarce on the ground. We need to put highly trained staff to the best use.
And so you implemented this. And what was because we often hear actually the first few weeks is quite intense.
Yes.
And you have all this, sometimes months of unmet demand that suddenly surfaces up. How did those first few weeks work?
So it was talking to the staff and kind of engaging them all, and then coming together to kind of plan rudimentary pathways to begin with. You know, this patient, this scenario comes up, what are you going to do with it? And making sure that they were all kind of mapped out. You say unmet demand, I say unlimited demand. So, you know, I think got to come to the realization that in a free at the point of access service that we've got, demand is actually unlimited. And, you know, we've got to, when we're implementing these things, we've got to bear that in mind always.
So I hear that quite a bit, but then you've also made your access a lot easier in a very positive way. But how do you square those two, that we're going to make access easier, but the demand's always going to keep coming?
So a lot of the demand that we're getting is failure demand. So that's demand generated by the system just failing, patients not being able to get through to you, patients calling you repeatedly because they know that they're going to have to call 8 o'clock that morning, 8 o'clock the next morning until they get an appointment. So when you make this more easy for patients, you actually get rid of quite a lot of that work. So yeah, that it was really just mapping all of that through, and also remember, if you've got staff that are tired, burnt out, exhausted, stressed out, patient care is going to suffer. So you've got to have, you know, psychological safety at heart as well. So what I'm trying to say is that when you build the system, you've got to make sure that you're protecting your staff as well, that you've got safeguards built in, that you can turn it off, you can pause it, and that you limit demand in that way.
And so I'm sure there's people listening who are thinking, oh, this, you know, we're struggling with the overwhelm. This sounds really great, but actually, how do I get the rest of the team on board? How do I deal with, you know, these concerns of, we're going to open the floodgates. You know, we're already just treading water, and we're going to make it easier for patients to get in touch. How did you get your team on board? What's your sort of answer to the practice thinking?
Well, you know, there were times when we were doing it at the beginning when we thought, what have we done? It was better, because if you think about it, you're getting a rapid highway access to a highly trained individual free of charge. So you're going to send one, you're going to get a reply, but you're going to send another, you're going to send another 2 for your family. And we found that happen to begin with. But actually what we found was a greater effect was that we were actually able to challenge a lot of those requests to more appropriate channels. So some of them even didn't need to come to the surgery. Some of them were nothing to do with the GP surgery. And we were able to bat those off and concentrate on people that really needed to see us.
And in those examples, or maybe other cases too, have you found the behaviour of your patients shift over time?
And that's the other thing. You modify patients, you nudge them into doing more self-empowerment, and also nudge them into accepting that actually, you know, your cold today doesn't really need to be seen by a doctor. It can be seen by a highly trained pharmacist. You know, your knee that's been problematic for the past 6 months doesn't really need to be seen by a doctor. We can you know, send that to a much better service where you'll get assessed much more thoroughly by an FCP, for instance. So patients actually have also learned that they're getting a better treatment just by using the system and us signposting them to the right service.
We've definitely seen this. The practice talk about this empowerment piece and patients feeling like they know if they do need to get in touch, it will be easier. And so they're comfortable, you know, going and using other, you know, being signposted to other channels. So I spoke about, you know, I think I said, if you know, if there's one thing I've learned from these practices and I'd love people to take away, is this: taking what would have been an appointment and trying to deal with it asynchronously, trying to deal with it through messaging. It'd be interesting in both if you found that, but then also if you have, like, what are some of the examples and the ways you do that? Sorry. All right. Sorry, we had an AV issue. But yeah, interested in how have you been able to, what are some of the things that before COVID would have been an appointment that now you can actually just deal with?
So you mentioned some of the UTIs, sick notes. I've got a list actually. Private referrals, blood tests, UTIs. We've even got Florey set up for starting statins. So there's a whole, you know, this is a revolution in primary care, whereby we can gather more information and deal with more people even more efficiently and more safely. So there's a whole bunch. You mentioned about 10,000 florries. So I think 1,000 of them probably are. So we're it's a really 21st century way of dealing with it without compromising on patient care. So we've got pathways for CKD, contraceptive pill checks, medication reviews, HRT reviews, all of that.
Yeah. What are some of the things looking forward that you're looking to change and iterate on in the practice? Are there any particular pathways or things at the moment you're trying to work out how you improve in these pathways?
For instance, recently we just did our gabapentinoid reviews, and making sure people are informed of teratogenicity of certain medications, and we can do that in a really an amazing way. Showing them videos and going through the stages of patient-centered learning, so that they're really empowered at their time and at their pace. So that's really useful.
Okay. Really, really good. It's always fascinating to hear from practices, because that, as I said, that's where most of the innovation comes from, and that's the thing we want to get much better at, how we share those across practices. So one of the things we commonly hear from practices is, we're keen to do this, but how and when? Like they've got maybe 6 weeks out of routine appointments booked in, so we can't even if we want to, there's just this backlog we have to get through before we can do that, and they're not getting through it. There just isn't the headspace, because there's flu season coming up, or they've got a CQC coming up, or there's constant pressures on practices. How did you create the headspace, and how would you, to other practices with that challenge, how would you recommend they create the headspace, especially thinking about now we're going into winter, more and more challenges with increased workload, more things from secondary care. How do you tell practices to manage that?
Primary care is very good at creating headspace. A little bit here, giving a little bit there. You give up your weekends for this or that. So if you think about this as a way to actually get even more headspace for the future, a little bit of investment in this. This is what you need to concentrate on rather than the other stuff. You'll actually find that life gets a lot easier for you.
Yeah.
So, we found that demand went through the roof during that first month, but I think all the practices that we've helped to go down this route have found that demand actually falls off therever, if you've got it implemented properly.
So was it about a month, you'd say?
For us, it was about a month. We went in the summer.
Yeah.
Now, when you choose to go is quite critical.
Yeah.
Winter is, a really difficult time for us, but you might find that it's still worth doing. But you have to have all that planning in place, the communications in place with your patients, most of all your staff actually, and making sure that you've got everything mapped out. And if you've got six weeks worth of back-to appointments, you're going to have to do something about that just to free up a little bit of capacity. You don't have to clear the whole books, but you need to have a little bit of maneuverability so that when you are actually triaging, you've got something to triage to.
Yeah. But that must be really hard then, when you've got, creating that headspace, when you've got patients every day coming in and trying to filter out what's urgent from them.
And you might have to buy in a little bit of headspace by having extra staff. I mean, certainly on the first week or so, we had floating staff. We had floating receptionist, admin, and a senior GP, just to make sure that the little, the little problems that would occur, iron them out straight away.
Right. So you made sure there was some sort of some extra capacity just
for those things. Absolutely.
Okay. And then one of the challenges we find is that patients are, societally, we talk about going to see your GP, not to get into touch with your practice and maybe be triaged to, a first contact physio. I'm interested in how you've tried to start shifting some of those perceptions and expectations that
it's not that big a problem. It's only a vocal few who read certain newspapers, and it has to be done this way. And but I think you've just got to plan for that. You're going to get those kind of patients, and you've just got to make sure that the people dealing with those patients are empowered to kind of push back in a nice way, in a safe way. So we made sure that in our practice, we've got a really strong zero tolerance policy for any rubbish like that, which kind of threats to staff or people being rude. we don't want that, because actually it compromises care for our thousands of other patients.
Yeah.
So you need to make sure that you're supporting your staff through it. And then when you do get those patients who say it has to be done this way, as you said, you just gently say, look, you wanted it this way, you got it this way, isn't this better? And actually they come around.
Yeah, we've one practice I was speaking to said, when patients get in touch and say, I want an appointment with my GP, through multiple iterations, they've got to a response of, I can help you with that. Need to ask some questions, then I can, and often what it comes down to is this, like, they're not saying no, like, you can get an appointment with the GP, but you might have to wait a few weeks, or someone can look at this like this afternoon and get back to you, and often like less than an hour, and then quite quickly, I think patients
make the choice,
make their mind up. And I'm interested, a lot of the focus, even when I think about it, is on these sort of acute presentations. Interested in if this way of working has changed any of how you deal with long-term conditions.
It does, because you've got to be careful in implementing this, because you can find that the waits for long-term conditions, if you haven't done it properly, just go on and on and on, and you don't get your cut points or the rest of it. So, but you have to, what we do almost daily when we're first implementing it is we tweaked the proportions of reds with a proportion of urgent appointments to the not so urgent appointments. So you've got to have all of those categories of appointments mapped out, and keep an eye on and change the proportions daily until you've got it right.
And you speak about sort of constant iteration. So, and as I said earlier, our users, the innovators, I think you've taken this to the extreme with sort of like building on top of us and hacking on top of us in a very positive way. Your triage system. Are you able to explain to people what you've done there?
So we just wanted we've got about 10 people at triage for us, all the senior staff, senior clinicians, and we just wanted to find a way of triaging in a standard way. So we basically mapped out all the routes for different types of appointments, different scenarios, and then we standardized the messages that would go to receptionists to take action on those. But more recently, we've actually built a little box, haven't we? So we press a button and an urgent appointment. We've got on our box. Go to our website; it will show you there. Wilmslow triage system. And for now, what we've got, because functionality from Accurx has increased, is we press a button, the patient gets an automatic self-book link for that category of appointment, and now even better, you can specify which clinician, because continuity is also really important.
And when you film that video, which I highly recommend watching, is the drone still in the tree?
The drone is still in the tree, I'm afraid, but thankfully it still had contact with my phone, so I could download
the video,
and the shot is brilliant.
But definitely worth checking out. It's very good. Our team really enjoyed seeing what you built on top, and hopefully when we put out a new release, it doesn't break too much of the interface.
Absolutely. What we would like, Jacob, live here is hotkeys.
Hotkeys, it's on our new. So the new version of the inbox we work on is a lot more keyboard friendly. So we'll have a play with it after this after the webinar. So if you had another practice here who's thinking about this way of working, like what would you say to convince them of it? If you had to summarize all these different lessons we spoke about.
So don't overthink it. It is a big step to take. You will come out of the other end and you will feel better for it. Don't be afraid to turn it off if things do go wrong. Safety first for your clinicians. Look after your staff and make sure they don't get overwhelmed.
It's a great summary.
Good.
Don't overthink it. I like it. And slightly different question then. Maybe a hard one. I don't know. If you put yourself in the shoes of a policymaker, Department of Health or NHS England, and think, okay, we've done this in our practice, and we've got some great learnings from it. That we think actually this is the future of how general practice could engage with and sort of manage their population with all the nuances of adapting it to local populations and iteration. How would you think about doing that? Because I think this really difficult trade-off, in innovation in general, between do we encourage everyone to work in their own way, which breeds innovation.
Absolutely.
But then when we found an innovation, how do we spread it without just dictating how every practice should work?
So primary care GPs are a resourceful bunch. They are innovators, all of them. And unfortunately, we used to have the primary care IT systems that were the envy of the world.
Yeah.
And then the 2004 contract came along and the government said, we own this, we're going to take care of all these contracts. And it's stagnated. So my plea to the policymakers is, don't commission white elephants like you've done and imposed on us in certain areas of the country. Give us the budgets and we will spend those pounds very, very efficiently. We as GPs see 90% of the patient contacts in the NHS on 8% of the budget. We know what efficiency is. We know how to spend that money. And we know that, if we spend our money on good products like Accurx's, the NHS is getting big value for money.
And what about if you go beyond just the software and the digital part? So how do you think about the actual way of working that you've implemented? Which when you go, when we visit total triage practices, it is a really sort of a nice experience just seeing how the practice works. How do you think about scaling and spreading that? Because I both agree with, as I said multiple times, the innovation will come from a resourceful bunch. Frontline staff are close to the problems, but we also see this challenge we spoke about before of that there's limited headspace to then go and do it, or there's risk aversion to going and working in a new way where it feels quite risky going and just opening up another channel. How do you think that can be done centrally?
Well, I think from a central, I'm not sure how you do it centrally, but certainly we're realizing that we've been working to the limitations of our software and clinical systems around us. What we've got now is the opportunity to work as we want, with the software being very flexible and adapting to how we want to do it. I think they need to give us autonomy with our budgets, and we will find out what works, and that good practice will spread, because which GP doesn't want to work more efficiently and with less stress and with more satisfaction?
So more autonomy, devolve those decisions.
We had a situation up in the northwest, where the commissioners commissioned a system. I won't name it, but it was absolutely atrocious. It was a retrograde step, and it was the NHS in that way actually encourages mediocrity, where we really have to be encouraging things like Accurx, things that actually revolutionise the way in which we deal with our patients.
And I'm keen to get into the Q&A. I have one more question, which is one that's on our mind quite a bit at the moment, is we're looking at the role that automation and AI can play in our product, but particularly in this challenge of managing all the demand that comes in. Where on the surface it's great, let's use AI, but actually when you start to unpick it, there's different ways we can approach it. Is that actually just for sorting things, but they still need to be dealt with by staff? Is that on the patient side of actually giving recommendations? Is that on the the staff side of giving recommendations? Is that there's lots of different channels, and as a very innovative GP who's already, as you say, building at the edges and innovating at the edges of our product, what sorts of automation do you think would have the most value for you?
So for us right now, I think it's the documents. And in this month, there are problems with a lot of practices who they're being overwhelmed by stuff being sent from the hospitals. And if there was a way in which we could read the content of the letters in a safe way, summarize it, and then pull out the codes that needs to be coded, that would be brilliant. And then even divert it to the patient, to the person who needs to read it. It doesn't always have to be a doctor. So that's crying out for automation right now, and AI. The AI that I've seen working so far in triage, to me, it doesn't work. It's not there yet. It will be there in the future, but it's not there yet, and it's I wouldn't trust it just yet. But I'm sure that's going to come soon as well.
That's one of the challenges we've had is there is I'm sure lots of people have played around with ChatGPT and things like that, but there's a big leap from that and having it played to trusting it for clinical decisions. And as a patient, even if the numbers were such that actually, yeah, this algorithm is more accurate than a person, which, as you say, is not the point we're at. I think there's still this thing of, but I want to hear it from a person. Even if that's in a message, I actually want to know it's coming from a person rather than from an algorithm.
And a lot of the time, the AI bot presents it in such a way that this is the truth. Actually, there's holes in it, and that can also give people a sort of false sense of security.
Yeah. So what I'm hearing with the document example is, let's automate away a lot of the sort of the manual, relatively lower value work that has to be done, but actually isn't, summarizing a letter or pulling out the codes is not where the complex decision making is.
Or finding results, which don't really need to be seen by you, and automatically informing the patient, that those kind of things.
Yeah. Great. Well, thanks for sharing those examples.
Thank you.
And thanks for sharing some of the experience of Wilmslow. Let's get into the Q&A. Should we go off here, or you happy to read out?
I'll just shut them up. So NHS England is demanding that we record everything in the appointment book for GPad. Is Accurx working to address this?
And I don't know if people heard that of these mics, but a question about GPad and if how we address that. I've got an answer for that. You've probably got. Do you want to?
So I know that Accurx are doing something for that, because last week there was a module that was activated where we record the outcome of each triage that we process in a really quick and easy way. So that is recording the data, and it is pulling the data. GPad is pulling the data out of our slots. You have to have them configured. Again, it's one of those scenarios where we have to bend and flex and put even more resources in just to please the people who are counting our stats. But hopefully, with the module that was delivered last week or the week before, that's going to be a thing of the past.
I've heard this comes up a lot, especially when I think it was number 7 in there of work from the inbox, not the appointment book. We don't save the request directly into the appointment book because it's not the most efficient way to work, and so we've tried to raise we have raised NHS England, actually, you want practice to work in this total triage way. We're happy to provide data, and they are now, I think, starting to publish the online consultation data by practice. I think some ICBs are more receptive to other forms of data like that, or the outcome data. I was talking to one practice that was having trouble with their ICB, saying, look, but your activity data is really low, and practice saying, yeah, but we're dealing with all these things through messaging. And the resolution ended up being just saying to the ICB, please just come to the practice and just come and watch them triage. And I think the ICB was actually quite surprised at quite how much demand and work they were getting through in triage that wasn't hitting the appointment book. So I'd also encourage practices to do that as well.
One for Dr. Ahmed. Can you share how you allocated your clinical staff to manage total triage?
Yeah, so the triager is a GP, and we have an admin reception person with us in a triage room, and we're planning to get secretaries and other people in the same room so we can talk together as well. But we used loads of R's roles as it went on, FCPs, pharmacists, all of that. And we've also worked with Accurx to make sure that we can now divert workflows directly to the PCN hub, which is actually all in the same building, but it just means that the other practices can do it as well.
And is it always one GP on triage?
It is. We've thought about 2 on a Monday morning.
You're right.
It got to that stage during the strep outbreak last Christmas, but we haven't needed it yet.
And that's with how many requests?
So we've got 16,000 patients.
Yeah.
On a Monday morning, a bad one, after a bank holiday weekend, for instance, we can get about 400 requests.
Wow.
It would have been more, but I think patient population has now kind of been trained to, go down the more appropriate route. So again, it all pays off. If you nudge people into making those decisions, in the long run, it will pay off.
I think some of that must be your smart. Well, a lot of it is also then your smart. Your
power triaging.
Power triage.
Yeah, I challenge anyone to triage as fast as us.
Can you limit incoming requests when using Accurx total triage? What happens if we have a lot of staff off sick to find urgency in the list?
One of the things that we've done at our place is we risk stratify all our triage appointment slots. So we know that if a patient, a clinician goes down, and people do go down because they're very tired right now, we can move all of those non-urgent slots safely to another time, but we know that those urgent slots will still get seen. So that's really important. That's another way of doing it, and it is the only way to deliver the mandates of the new contract. You know, the same day assessment as well.
So just to understand that, you've got, so your triage volumes continue coming in.
Yeah.
But if the GP who would have been triaging is off.
No, I'm talking about someone you know, who's got a normal clinic appointment.
Ah, right, okay.
If the GP who's triaging goes off, someone has to step in.
But for anyone's slots, you know which ones need to be shifted, and
they're all categorized very, very
right.
clearly.
Okay.
Yeah.
One thing limits is an interesting one, because we provide the ability to limit. We actually sort of put it off for quite a while because we didn't want to recreate the 8 a.m. phone ring on the internet.
Yeah.
And I definitely understand you know, we just don't have enough staff and this is unsafe, we need to limit. And so some practices use that. The one and I'm interested in your thoughts here, because I'm a bit more
We've never had
skeptical about, right? Well, is the just like day-to-day limits of, you know, saying,
we don't have any limits,
right? Okay.
Or the only limit we have is in the afternoon before the on-call finishes. It turns off.
Yeah.
Again, just to make sure that you preserve the sanity of your staff.
Yeah.
So people have experimented with what times they are open from. Certainly don't leave it on overnight, and certainly don't leave it on over a bank holiday weekend. Because you will have mutiny. So you have to, again, it's all down to the fact that demand is unlimited, and you need to make sure that the slots that you're open, that you just determine those, but do turn it off before your on-call shift finishes.
Sounds like a lesson from experience.
Definitely.
How much quicker is it to close a request remotely compared to closing by telephone consultation or face-to-face on average? Some clinicians are not convinced it will actually save them time once they've opened the record, checked the history, organized the prescription, etc.
You go for it.
Yeah, no, happy to talk to this. I mean, I think it varies a lot on what it is, and definitely a failure of this way of working would be to do things over messaging that would be much faster over the phone, or much faster in person, or even worse, to sort of do a phone call that you're going to need to, going to need to see that patient in person. The fastest examples we see are some of these like higher volume patient gets in touch with a sore throat. We've tried to make it, I think it's 4 clicks to reply with a Flory, 3 or 4 clicks to reply with a Flory. So that, practices who are used to doing this is now almost like muscle memory. Sore throat Flory, and then they can have a scan of that. And decide, are they just going to send advice, say this is likely viral self-limiting, and either they use one of our templates or they have templates for that, or do they want to get the patient in to see their ANP, and then they send out a self-book link. So in that example, that, ideally to resolution, even excluding the booking case, even actually just responding and saying, okay, it's likely viral. If it's, if it hasn't gone away in a week, then you can get back in touch. Should be under a minute of a clinician's time, doing those responses. I don't know if that sounds.
Yeah, absolutely. I mean, we have a kind of unspoken rule that if you can't decide on the triage pathway within 30 seconds, we kind of book it in for an urgent or a routine. But yes, I think with experience and with practice, you'll get to a stage where you'll be dealing with those really, really quickly and efficiently and safely. We defaulted to face-to-face, 18 months ago, and we're finding, we're delivering a whole shed loads of more appointments. We did 63,000 appointments, 94% of them face-to-face last year alone. That's on a 16,000 list. So, I think if you try it, you'll find that it will work for you. You can always turn it off if it doesn't work.
Don't overthink it, and you can always turn it off.
Absolutely.
Yeah. How do you manage the patients who refuse to share their clinical information with a receptionist, those who label their problem as private? Yeah,
well, I mean, that's a really common scenario. It hasn't, that scenario is very old. And we insist that actually, if you don't give us the information, we won't be able to triage you to the slot where you can get the best treatment in the quickest time. And we're quite firm with that. There are rules that both the clinician and the patient have to deal with. You cannot have your problem just a direct consultation with a GP, and only the GP knows what that consultation is about. It's wrong. It doesn't work. We haven't got that level of resources to have that kind of Rolls-Royce service.
I don't know if you do this in your practice, but I know some practices record their phone message.
Yeah.
One of the GPs saying, "Hi, it's Dr. So and so. One of our reception team will ask you some questions, and this is why we do it, to try and inform patients."
It's not been that much of a problem for us. It really hasn't. I think when they get that level of service, really quick and responsive. I mean, just look at our Google reviews. They are completely unsolicited, and we've got 400 odd 5-star reviews. It's the patient. I've been practicing at our place for 23 years. I've never known a time where we've been able to make such a difference to patient care in one fell swoop.
Last 2 questions from me. How do you work out the proportion of appointments between urgent on the day and routine?
So that it was trial and error, but having spoken to a lot of the practices who do it now, we're averaging about 48-49% of on the day urgent appointments. But you're gonna have to make that decision yourself to make sure that you're running your QAF, your long-term conditions, and you're getting it all right, in a safe manner. And there will be patients who will be waiting sometimes, but we actually found that our routine appointment waits decreased when we implemented the system. So I think they fell by about a week or so, and right now it's about 2 weeks, which isn't bad for non-urgent stuff. Obviously, the semi-urgent and the urgent stuff gets seen within, the urgent stuff that session, and the semi-urgent stuff within that week.
And is that at 48-49%? I'm guessing some of that's seasonal, with obviously winter, but half terms and things like that.
Absolutely, you'll find that things get much worse during outbreaks. And you just have to flex with the system. So you have to keep an eye on it and tweak it. We're not tweaking it as much these days because I think we've got the balance right. And remember, our clinicians deserve a break. And if there are unfilled slots, there are unfilled slots. They have a break. We are human. We're not machines.
What's the experience of total triage practices where patients do not speak or understand English?
I don't know, about your population. Yeah, we've got quite a big refugee population, and we're actually finding that because it's written, it's much easier to translate, that they can actually translate themselves through Google Translate. And, we get it's better, in fact, because we've got this medium in writing that is already translated, and you can communicate much easier with them.
And that's also something we're working on. So we've got a version of patient triage submissions that can be translated, and we're also looking at how we translate the messages going out to patients, because definitely see that need.
And the other question that I get a lot is, those patients who can't use online stuff. And remember, you are freeing up your lines by pushing the vast majority of people onto the online system. So your lines, your receptionists, as you said, they're much more capable to, they've got more time to handle the elderly and fill out a form for them. And the elderly love it.
Yeah, and the thing I've also always found with that, because it is a very important question of making sure the service is accessible to the whole population. But I find that we often forget how inaccessible the current the status quo was. Absolutely. In terms of actually there aren't a lot of people. There are lots of people who can't just take a phone call in a 3 or 4 hour window during the morning because they're a teacher or they're they're working they're in an office environment, a retail environment. They can't do that. And actually the status quo also the status quo did exclude people through different channels.
It was awful for working people. I'm a patient as well. The 8 o'clock wait and being told to call again and again and again is awful. You shouldn't be doing that. I know the system is under strain, but there are other ways in which we can operate to mitigate that.
Yeah. Great. Well, thanks so much for joining us. Thanks for sharing some of the lessons from Wilmslow. Really impressive practice. Do check out the video online on the
Wilmslow triage system.
It's a great YouTube video. And if you have more questions about total triage, or you want to hear from other practices who've done it, we run sessions where we can pair you with practices to help you on that journey. and hear some of those learnings. And as always, you know where to find us if you've got support questions or you want to get set up and work in this way. Thanks so much for joining, and look forward to seeing you soon. And thanks, Amar, for being with us.